So I'll start the recording. This is continuation of yesterday's lecture. So last time we talked about a couple different disorders. We talked about spina bifida. We had gone back through and we had talked about Downs a little bit. We talked about cerebral palsy. So we'd finished on spina bifida, right? And what was spina bifida caused by again? What is spina bifida caused by? Jeanette, you can't see? Is it because you don't have the screen up? I was going to say. Spina bifida is caused by a failure or closure of the neural tube, right? Yeah, heat and genetics typically, and your teratogens a lot as well. With kids, with kids with spina bifida, the main thing we're going to focus on is preventing deformity and any type of stuff that goes along with it. Because spina bifida, like I said with the lecture yesterday, they've got all these wonderful deformities of the foot that can happen, right? So all these wonderful deformities of the foot and cerebellum and everything like that can occur with spina bifida. So we have to make sure that we prevent any of those deformities from developing, or at least prevent them. The weird thing about spina bifida, and I don't know where this, why this is, and I haven't really ever looked it up, they have a severe latex allergy. Almost every single one I've ever seen has a severe latex allergy. Good news is most of our hospital gloves are nitrite now. But I'd be curious right now if we're even getting nitrite gloves or if they're, we're taking whatever we can get. Early intervention's key, right? Home instruction is important for the parents at this point. We get to preschool, facilitate motor development. And the main thing here is this tethered cord syndrome, right? That's the main thing we've got to watch for with them. What do you think tethered cord syndrome, so if that cord gets bound down, what do you think it's going to look like to us as physical therapists? What do you think they're going to present like? So if the cord gets stuck and the signals are getting cut off from the legs, it's going to look a lot like autonomic dysreflexia, but just long term, right? So blood pressure is going to change. Urological function is going to change. Mood is going to change. Function of the lower extremity obviously is going to change. You're going to get lower motor neuron symptoms, right? And then the body is going to progress towards scoliosis in order to relieve that tether. So the body's going to slowly kind of rotate forward to reduce that pressure on it. Now, if it's stuck to the back of the spine, that can actually increase it. They can also end up with this hydromelia, which we talked about yesterday, was excess spinal fluid moving down into that spinal cord. This is where we start. A lot of times in PT, we're not going to see them until they get into this school age. For some reason, we don't see them. The parents don't bring them in until they're school age, and by that time we're already behind the 8 ball on them. Any activity that encourages cardiovascular challenge, muscle strength, and hand-eye coordination, anything like that. But we want to make sure that we help them get independent. Helping them get independent will allow them to have a more fulfilling life later on down the road, especially, preventing any type of, side effects from it, obesity, social incontinence, recurrent urinary tract infections, right? What's a sign of a UTI? What are signs and symptoms of UTIs? Confusion's a big one. We miss that one a lot of times. Back pain, good. How about the most common one? Yeah, hard to pee and burning while urination. Yeah, all those are common symptoms, right? Are we right now at more risk to get UTI since we're spending so much time at home? Or less risk? What do you think? Yeah, can lead to kidney stones, absolutely. So what do you think? With everyone being stuck at home, do you think we're getting greater risks of UTIs? Okay, why? That's actually the right answer. There's the catch right there, Russell. I would be willing to bet if you took the average of people showering at home in the United States right now, it's a lot lower in hygiene than you would think. I would be willing to bet. So now, the people that might not have showered except for every other day are now showering once a week. Less holding it, though. You're exactly correct, so Krista, because we can actually get to the restroom without having to interrupt a class. But it's just interesting. There was a whole write-up on that in GQ or one of those men's magazines talking about how spouses are finding their male companions less attractive because they're not showering as much. I just thought it was amusing that people are deciding not to shower. I don't know why. That just is kind of disgusting. But hey, you do you, bro. All right. Duchenne's. All right. So Duchenne's looks a lot like the opposite of what? And women are, hey, they just looked at it from the men's standpoint, but hey. I saw a great video that, yeah, exactly. I saw a great video of the husband and wife, and the wife walks up to the husband and said, "Now that we're doing this stay-at-home thing, you need to stop doing that." And the husband says, "Doing what?" And she just waves at him and goes, "That." Relationships are definitely being troubled right now. That's for sure. Muscular dystrophy is a lot of times, we talked about this before, it looks like the sort of the different side of the coin of what other disease? ALS, right? Good. So with muscular dystrophy, before you go any further, let's kind of review what we looked at. Does muscular dystrophy go proximal to distal, distal to proximal? Proximal to distal. Good job, Ian. What is actually happening to the muscle in muscular dystrophy? It's going to atrophy, right? And then what's going to happen to it after it atrophies? It changes composition. What does it turn into? Yeah, you lose the muscle. Yeah, and then it turns into adipose. Exactly, Alex. Good job. Right? So the muscle physically, literally, your bicep, as it kind of wastes away, will become adipose. Now, normally, we don't have that problem, right? Because we have the actin, the myosin, the keep it. Even if we atrophied down to, even if you look at like, little old Millie who's 95 years old and is atrophied down to nothing, she still has biceps. If you look at them, they're still there, right? Sometimes you can see them a little closer on her than you can on a bodybuilder because they're all kind of no skin and everything's tight and falling off her, right? But she's still got muscle there. But a kid that's got muscular dystrophy, literally, when you tell them that they have to, do stuff, it's not their fault. It's not like it's not like they're lazy, right? But because their muscles are breaking down, it's going to make them more lazy, right? It is progressive. So when a disease is progressive, what does that mean? Oh, I'm sorry for that, Alex. Yeah, it's only going to get worse, right? It doesn't ever get better. I can't sit still for some reason today. So that's the main thing here. The child's going to become weaker and weaker and usually dies from respiratory infection or cardiorespiratory insufficiency in the late teens or early 20s. Now, we have moved into the fact that we can get them into their 30s, right? But let's be honest, what kind of a life are they going to have in their late 20s and 30s if we get them there? Yeah, poor, right? Do any of you guys know who Steve Gleason is? Football, good. What team? Saints, right? Yes. He ruined the Atlanta Falcons one season, so I'll never forgive him for that. Steve Gleason was a football player, specifically special teams. Yeah, he blocked the punt. You're exactly correct. And caused New Orleans to win their first game back in the Superdome after Katrina, right? I still think that was thrown, but don't tell them that. Don't tell anyone else that. But he's got ALS, right? And he's got a lot of money. He's got a lot of foundation providing him with life. But if you look at the life he lives right now, right? He's confined to a wheelchair. He can only speak by speech board. His wife and his whole family has to take care of him for as long as he lives. Is that really life? I know. What would you guys think to that? Would you want to live that way? Okay, Elijah says no. How about would you want to live that way? No. Okay, somebody's saying no, right? Good. I mean, yeah, Jen, it's really hard. Okay, good. Okay, Alex. That's a fair point. I don't know that I would want to. I'd have a hard problem with anyone having to take care of me. I think probably because I took care of my ex-wife. Yeah, and try to get better. You can't even hope, but it's probably not going to. So that's what I'm talking about. These people with muscular dystrophy. I really, my heart goes to them because they see where the train tunnel is leading, and they can't get out of the tunnel. Right? It is just really, really demoralizing that way. And a lot of times, again, most diseases they're not going to die from muscular dystrophy, right? Even this COVID virus that we have right now, people are saying, well, COVID's not killing people, they're dying from pneumonia. Exactly, Melissa. Yeah, I love it. People, COVID's not killing people, they're dying from pneumonia. What do you think's causing pneumonia, you idiot? Right? Of course, they may not be dying directly from COVID, they're dying from the complications from the disease. That's important to understand, right? These people are going to die. But if you think about it, to me, I think ALS would be a little easier to deal with to me. But just the fact that everything in my core dies and then I want to walk, but my core can't function, that just drives me. I don't know. It's weird. Males will inherit from their mothers who are asymptomatic. And here's the defect. It's at XPG or XP21. I think they should. I agree with you, Russell. I think we should have a class on, let's have a class on basket weaving too. I actually just took a class on cross stitch, so shh, be quiet. So yes, you do have to know the two things you have to know as far as the pathology. Underwater basket weaving, I like it, with no respiration. Two things you have to know about the pathology of muscular dystrophy is it's a mutation at the XP21 layer of the chromosome, and it's for the synthesis of the protein dystrophin. Those are the two main things you need to know about the pathology. XP21, dystrophin. Right? So that XP21 is the loci on the actual chromosome that's causing the defect. Protein dystrophin is what we normally produce, and you have the lack of producing or the lack of sensitivity to that protein. Eventually, they'll develop contractures and postural alignment, scoliosis, decreased respiratory capacity, fatigue, and occasional obesity. They're going to get obesity most times because they're just sitting in a wheelchair, right? About how long, if you have full-on Duchenne's, until you're in a wheelchair? What do you think? What do you guys think? Depends on onset, right? Yeah, here's the interesting thing about it, Alex, is the onset's birth. What you're talking about is depends upon when diagnosed. Because somebody that's got Duchenne's has always had Duchenne's. It's just been undiagnosed. No, I'm just letting you know, you're fine. No, I'm just and that can be a confusing. That's why I'm using this as a learning tool here. They've always had Duchenne's. It's just they haven't shown any signs of it. When they start showing signs, then they're diagnosed with Duchenne's, right? So it's really important to understand that they've always, like a person that has ALS, has pretty much always had ALS, the assumption is. It's just that switch hasn't been turned on yet, right? So usually they're going to say late teens, they're usually in a wheelchair, right? So by the time you get to 13, 14, you're starting to progress towards it. 15, 16, you're in a wheelchair, right? And think about that time period for kids. You guys remember back to when you were 15, 16. Bison still looks like it. Well, so there is some teratogenic, not teratogenic, that's the word I want to use, environmental component to ALS, Russell. There's some component to it, but also a lot of the studies lately have been showing that environmental component to ALS probably just flips the switch. Does that make sense? That you've had the predisposition for ALS, and then that environmental component turns it on. So that would be, think about though, if we could, for both Duchenne's and for ALS, if we can come up with a genetic test at birth, that would be really good, wouldn't it? That, usually, well, that again, the same thing with ALS. Most of the times you don't. Most of the times Duchenne's is going to kick in as soon as they start getting ambulatory. It's when we're going to notice it, because we're going to notice the Gower sign. Some of the others, Becker's muscular dystrophy can develop later in teenage years. But Duchenne's usually starts as soon as they're walking, it starts showing. Yeah, right, Jen. So that's a really interesting question. I think I would want to know, especially if it was my kid. But then again, the world does not need me to have a kid. Trust me. But I mean, I'm just thinking that wouldn't it be nice to know that? Right, it's French. It's sad, right? But could you imagine, like, if you know that, because then you could get into some of these trials that are out there. That's kind of my thought process is, because most of the times you can't get into the clinical trials for these diseases unless you've been diagnosed before onset of X amount of symptoms, right? But if you knew that you have the predisposition for it, maybe parents, family members, you can prevent yourselves from putting you in a situation where that gene gets turned on. I don't know. It's just something I was thinking about. I mean, it's a double-edged sword, because, you know, getting told that your baby's born and the baby will have ALS at some point in life, that's kind of sad, right? That was part of, what was that movie with Hawkeye, Jeremy Renner, where the aliens came in? I forgot that, but that was the whole concept between the lady in the movie knew that her daughter was eventually going to be diagnosed with the disease because she could see the future. But anyway, you know, I don't know. I went totally off tangent there. Let's get back on tangent. Males, again, inherit it. Secondary impairments we talked about. Earliest sign is reluctance to run or walk, falling, difficulty getting up or off the floor, and they use Gower sign, right? So Gower sign is when the patient gets up, they're going to primarily use their hands and they're going to walk up their body to stand up, right? So they're going to start by pushing on their legs and they're going to use their hands to straighten their core. That tells you their erector spinae group is not properly developed. Clumsiness is really common. Toe walking can happen here too, but then, you know, I don't know, could some of the signs of CP be undiagnosed Duchenne's? Maybe. Clumsiness, increased size of muscle groups, especially gastroc and infraspinatus and deltoids. And then proximal muscles seem to weaken faster. So they're going to eventually decline. One thing, I think I'm going to talk about interventions next, if I remember. Well, early weakness of the hip and knees result in exaggerated lumbar lordosis. Yeah, these kids tend to walk with that cowboy gait where they're walking really wide, almost like they're in the old cowboy movie. They will typically develop contractures of their plantar flexors, which will put them into that whole toe walking idea. Scoliosis is often noted because of maldeformity and maldevelopment of the spine. Coughing becomes more difficult, which makes sense. If my core muscles start weakening, right, they're going to have problems coughing. Can we help a patient cough? What do you think? Yeah, right? There is assisted coughing techniques, right? Assisted coughing techniques is nothing more than the patient actively trying to cough while you're doing the abdominal thrust, right? And that can help them cough. But if they can't cough, what else can we teach them to do to help clear their lungs? Huff, yes, right? Huffing, we can get that deep long and the deep short huffing, right? And everything as much as we can out of it. But we may also have to teach them how to clear their throat with suction and stuff like that, so that comes into play as well. In the intervention, we want to prevent deformity, prolong functional capacity, facilitate development of persistence levels, and control pain. If your muscles start weakening, you're going to get pain. So they're going to be in pain pretty much constantly, especially when they hit their late teenage years. A lot of them are in chronic pain. HEP family education is important. Active exercise as long as possible. So this is what I wanted to talk about. With kids with Duchenne's, it is not recommended you actively push them in cardio exercise. Why do you think that is? Yeah, it overloads it, right? And it'll actually make the disease worse. I don't know if I told you guys, but I had a clinic that I used to work for that any kid that came in got on the treadmill. Mainly because you're trying to kind of wear the kid out a little bit before you work with them. if you put a kid like this on the treadmill, you're actually speeding up the development of his disease. So it's negligent practice. Same for ALS in late stages, exactly. It's going to speed up the process. That doesn't mean that walking is not good for them, right? It just means we're not going to put them on the treadmill and make them run at 6 miles an hour, right? They can get on the treadmill and walk, but we want a slow, controlled walk, focusing more on that heel-toe strike and the follow-through of normal gait than necessarily cardio development. Exactly, Alex. You don't want to totally stress any patient, but MD, it will progress, right? And this is a mistake a lot of new clinicians make. One of good questions. Is it the same for Becker's? I mean, it is in a way. Becker's progresses a little bit differently with the dystrophin. So again, with most muscular dystrophy, and actually Alex Lopez made a great comment, we're looking at functional endurance. We're not looking for them to be able to run a mile. We're not looking for them to go down and do the muscular dystrophy walk. Probably not a good idea for them to do that, right? But we're looking for them, do they have the ability to have enough endurance to get through the day? Does that make sense? We want them to have that ability that they can get through a full day without being totally fatigued, or at least minimizing that fatigue. That means we're going to teach them a lot of what type of techniques. Energy conservation. Yeah, I mean, if not going to get nothing else out of me, you got that. You can teach them a lot of energy conservation techniques where we're going to teach them how to maximize their function, right? If I have a weak core, is it going to be hard for me to stand up? Say from a chair like I am right now. Is it going to be hard, right? All right, so how do I make it easier for me to stand up? Momentum, great, right? What about raising the chair up? Assistive device, good. Can you use the arms, good. But what about just raising the chair up? Will that help me get up a little bit better? Right now, I like my chair on the floor. My knees are almost in my chest. That's going to take a lot of force generated for me to stand up, right? But raising the chair can help. Also, getting some of those chairs, especially if they spend a lot of time at home, those chairs that help them stand up, right? We've got to balance it. We don't want them being completely dependent on assistive devices, but at the same time, we want to teach them enough that it conserves energy, right? So if, during the day, if they've got the energy, they should be standing up on their own. But if at night they're starting to get worn out, then they can use those assistive devices to get up and moving. Wheelchair use, prolonged ambulation as much as we can. Wheelchair use will be eventual, right? Orthotics care and use is big. Weight control. Why would we want to make sure that they're under effective diet and weight control? Why do you think we want to make sure they don't get less stress in the body? Exactly, right? And it also is easier to move when you have less weight. I feel like I'm actually starting to, yeah, exactly. It's getting difficult to move. I feel like that right now. I feel like I gained like 40 pounds. I know I haven't, but I feel like I've gained 40 pounds because, I'm not getting as much exercise as I was getting. And so I think we're going to face, that's going to be one of the things we're going to face when we come out of this pandemic is a lot more people are going to be overweight and having more problems, but that's beside the point. Minimize spine deformity. How can we help them to keep from getting a spine deformity? Posture, right? So they're sitting like this, playing video games all day long like I do, right? Got to help them get upright, get the neck back, right? Chin tucks. We also may have to provide them with orthotics to keep that body nice and tight, right? Straight. Something as simple as there's an orthotic that just has a pressure point on the chest that when they start curving forward, it pushes into them, so it reminds them to sit up straight. All of those can be really useful for these patients. Facilitating sleep, they need to get a regular regimen of sleep. I think right now, this is the hardest for me at least. I don't know about you guys, but this is the hardest for me. For some reason, my sleep schedule is just all jacked up. Right? Yeah, and it's like, and I'm only sleeping about, I normally sleep 4 hours, but now my sleep schedule's a really weird 4 hours a night. Sometimes it's from 8 to midnight, and then sometimes it's like midnight to 4, go to sleep at 2 a.m. Exactly. So it's really messing us up. And why is that? Because we're not spending as much time in the sun. I was going to say, and then for Justin, it's like 12:45. See if Justin's even awake. See, I picked on me. He's not even here. There is no reason to get, unless you're working, right? For me, I have to. Standing in the back here. Good. At least you're getting out and getting the sun. But most people, I think they're getting some seasonal affective disorder by being stuck inside, right? And that's just going out of crazy. But with these patients, we've got to do that too. We got to get them a good sleep. They've actually got to get 8 hours of sleep. See, that's a benefit for having little screaming alarm clocks, Melissa. I do not begrudge you guys having them at all. I'm so glad that I don't have kids. Dogs even sleep in. Exactly. The dogs are happy. They're like, oh, we're going to sleep some more, Mom? Okay. ADLs, you got to teach them how to minimize their energy use during ADLs, right? Let's go back over here. So prematurity is the last thing we're going to talk about today. So a lot of times you hear them referred to as preemies, right? That's the term for a child who's born before 37 weeks of gestation. Adjusted age will be accounted for until the second birthday. So, they're not going to be, we're not going to say necessarily they're functionally 1 year old until we've hit that normal 9 months of gestation plus 1 year. Now, the birth date is still going to be whatever the birth date is, right? But progressively, a lot of science has shown that even if they're born a preemie, say that the baby's born, at the, 8-month mark, right? If they're born at the 8-month mark, we can't expect them 1 month later to be where a baby that's 1 month old would be, because they've lost one full month of in utero development. So they've got a delay on their progress, and we have to be aware of that. Factors contributing to premature birth is varied. Premature eclampsia is a big one, placenta previa, abruptio placentae. So all of those, when you're looking at all of those, it's a problem with the placenta, right? So, and I know some of you mothers are going to be kind of, this is a hard topic to talk about here with kids. All the kids are, right? Incompetent cervix. I just think we could have picked a better term for that. I'm just saying. Every time I see that term, and I'm just like, can't we come up with a better term than that? Darn you, cervix, you're incompetent. Abnormal uterine shape. What could lead to an abnormal uterine shape? What do you think could lead to interuterine shape problems? Multiple births definitely can, yes. What about the mother's size? Could that affect it? Let's say mommy, yeah, right? Let's say mommy is, 4'11" and 85 pounds. And now is going to have a baby, right? And how much weight does a normal person gain with a baby? Mothers, you should know this. 30? Good Lord. Depends on how much they eat her, right? Yeah, it actually can be anywhere from 25 to 50 pounds, right? So now you got an adult who's 4'11", 85 pounds that is literally doubling their body weight. And they're going to be carrying a child that, if you're lucky, the baby's normal size, right? If you're unlucky, you're like my mom, and you carry a child who's 12 pounds, 10 ounces. And that does happen. It's true, Chris. It can affect you, especially with pregnancy, right? But let's say that, that's the baby's fault. Exactly, Jacqueline. I'm born to a mother that's really small. The uterus is not going to be able to adapt to my size as a baby, so that can cause problems with baby development. That may force premature birth. Infection, other illness, preterm labor, and the other major one that leads to prematurity is drug use. Specifically, what drugs are going to lead to premature baby birth? Meth, good. One other one. Actually, two other ones, but one that we're really worried about in the city. Alcohol can. Heroin. There we go. Coke can as well. Specifically cocaine, not Coke. But heroin and meth are the two major ones that lead to premature birth, especially synthetic heroines. And right now, the major one we're dealing with in hospitals is the synthetic. What's that drug called again? Fentanyl. There we go. Synthetic fentanyl. they're causing some premature births, right? So let's take that baby who needs an extra month of development, birth that baby early, and now the baby is born addicted to heroin. It is sad, right? Let's think about that for a second. I mean, what chance did we just give that child to survive? Right? You've got a baby that's slim, right? You got a baby that's born and now they are addicted to heroin, so they now have to be on methadone in the premature, in the NICU, right? And if you guys never get a chance, I mean, Google some of these videos of babies that are born to addicted mothers, right? If they do survive, it is heartbreaking, Jacqueline. I mean, treating them, I will say this: if you want to work in the premature, in the NICU, stuff like that, if you want to work with babies like this, you really, really, really have to be able to shut off your heart. Not shut off your heart for caring, right? But be able to shut off your heart and understand that tomorrow that baby may not be there, right? I have nothing, absolutely nothing but pure respect for all the nurses in the NICU. I can't imagine how hard their life has to be, that they are constantly caring for babies that about 40% of them don't make it through. There can be, absolutely. Consequences, yes, absolutely there are, Russell, and that could also be an equal problem. Yeah, Chris, that's just sad, right? And there actually is a large amount of babies out there that are born to people that are on drugs that are up for adoption that nobody wants to take. Because I feel for the parents that don't want to take them, but you got to think about it. Is there's a chance that they're going to get to 6 or 7 and be dead? Do you did some great things for that child, but just imagine what your heart's like at that point. Yeah, right. It's like this is the one thing. This is the one thing that makes me probably the most angry working in pediatrics, is because that baby did nothing to deserve the problem that that child is going through, right? And I know some of you are religious, but I love it when I hear people say, well, the baby's being punished for the sins of the parent. That infuriates me on so many levels. Trust me, you'll get to hear it if you ever work in places like that. There'll be some not doctors, but that's not how religion works. Evidently it is. And that's actually in the Bible, that the child will be punished for the sins of the parents, specifically Old Testament, but it is in the Bible. That blows my mind, especially, and it's even, it's in most religious texts, actually. It's also in the old Assyrian religions and stuff like that as well, that the sins will be revisited upon your children. It's wrong, right, Elijah? I'm not saying it's right or wrong, but I just can't imagine having that mental delusion that this child deserves. Exactly, Mike. Or maybe, Mike, what it is God only made you so tall until you're a perfect height. Think of it that way. Parents should be punished, and there are some things, but let's think about this. We know for a fact the best chance of childhood development, it doesn't matter, is in the home with 2 cohabiting parents. Now, note, I am not saying that those parents have to be male-female, male-male, female-female. They have to be cohabiting parents. That is the best chance for normal childhood development. The best chance for that development to be is the biological parents. But so now mom comes in, mom's hooked on drugs or whatever, baby's born hooked on drugs, and mom goes to jail because of punishing baby. Now baby's at a deficit because they're addicted to drugs. They're maybe premature. Their body's not developing right. And we've taken away the mom, which is their best chance at actually developing normal. So that's, we're already setting these kids up for failure. And that's if these kids make it out of the NICU, because a lot of them don't. A lot of them make it out in a pine box. That's how they make it out of the NICUs. It's really sad. Fetal factors, congenital deformity, right? Again, talking about mother size. But don't just always think that that's a small mother, right? Because what if you have a mother that is morbidly obese? Is that going to affect the size of the the uterus? Yeah, absolutely. Right? So it's not always, I'm not blaming small people. Please don't think that. I'm just saying small people typically have a small uterus, which leads to children having problems. It also leads to really, really difficult births and difficult child carrying. It just is. Same thing with bigger people. They have the same problem, right? Because that excess adipose just weighs down on that pelvic floor and then compresses the uterus. So all of that comes into play with this, right? Congenital deformity is going to cause all kinds of problems, right? Multiple pregnancies can lead to problems. What makes sense? So here's my question. Then why do we have why would the human race develop in having multiple births? What do you think? Like, what developmental thing? When did it happen that we started having, you keep species alive, maybe, right? But if we know that predisposes maybe those babies having problems, it's genetic. The genetic development of twins and triplets and quintuplets and octomoms, it just amazes me. I don't know why we. Yeah, maybe. Okay, that's possible too. Alex, you're 100%. But what I'm just saying is not only multiple births, as in like multiple pregnancies. I'm also talking about multiple babies in one pregnancy. What was the genetic development, or what was the genetic reason for having twins? Now we know that there's a science behind it, that it's the ova kind of separating and stuff like that. That's beside the point. But it just is amazing when you think about that genetically. Why did we develop that, right? But then you think about like the other animal kingdom, like cats, right? When a cat has a baby, it's not like they have one kitten, right? So be aware that if you have a cat and that cat gets pregnant, get ready for lots of cats. So we're unique in the animal kingdom that we give birth to one offspring. So maybe we genetically developed, and that's the new norm for us. Whereas before, maybe we had more pregnancies. And maybe, I don't know. Fetal infection. What could cause baby to get an infection in utero? Okay. Smoking. Yep. You're right. If we gave birth in egg form, we would have more, right? Parents getting sick. Good. You did spell it right, Jacqueline. You're right. Right. What's the disease we worry about if you do have cats in the house? Toxoplasmosis. Good, right? And what's that from? What part of the cat? Right. And I always say it's a shitty disease. Come on, it's kind of funny. It's not funny for people that have it, right? Toxoplasmosis is the big one. So that can affect the baby as well. So any type of infection that affects mom can ultimately affect baby, right? Because mom and baby are connected, right, via that cord. Now, does mom's blood ever actually go into baby? No, right? There's a barrier, right? Everything kind of transfers over the barrier. But if oxygen, nutrients, and everything else can cross that barrier, viruses can too. It's not quite as effective as the blood-brain barrier. So a lot of that can transfer over. What are some clinical features of the patient? Depends on their gestational age, illness presence, absence of genetic disorders, other factors. Usually preemies have less body fat. What is that going to propose? If the baby is born with less body fat, what can that predispose them to? You're like, yes, make me have less body fat. Hypothermia, good, right? So yeah, so the baby's born, it doesn't have the body fat to keep it warm, which is why we often have to keep them in the little incubators, right, to keep them nice and warm. Less muscle tone is common because they didn't have the normal chance to develop in the uterus. Physically smaller, and I am not joking when I say that I've treated a baby that is the size of my hand, right, or smaller than my hand. It just, to see that we've come science-wise, that those babies can be viable, just, it's amazing and terrifying at the same time to me. Less able to regulate the body state, right? They're also less able to regulate their emotions because, again, development in utero does help emotional development with the baby. You don't think it does, right? But there are a lot of studies that show that mothers that talk to their baby, while they're pregnant, that provide the baby with regular stimulus, stuff like that, the babies come out a little bit more well-adjusted than somebody that doesn't pay any attention to the baby during childbirth, right? Less maturation of organ systems causing significant risks. My ex-wife's aunt gave birth to a child who was preemie, and he was born with half of a right lung because his lung didn't develop, right? So they had to do at birth, they had to do all kinds of surgeries on him in order for him to survive. He was born at 39 weeks, I think. But when you're born that early, your body hasn't been given the ability to survive, right? You're not given the best chance for you to live. We're going to score them on the APGAR score, right? Tabulated at 1 to 5 minutes after birth. We'll score the heart rate, respiratory rate, muscle tone, reflex irritability, and color, right? Other complications that can develop. RDS. What's RDS? 38 weeks, yeah. Or 39 weeks, yes, Melissa. You know what I will say this about this, and I will continue on this. Caleb, who is the kid that is, did I say 38 weeks? What did I say? Hold on. Not 39 weeks. Oh my God. 28 weeks. I'm sorry. Thank you for correcting me. I'm like, wait. Yeah, I did say it wrong. Caleb just actually finished his first marathon over the weekend. And I have a little concern with the fact that Australia is holding marathons right now. We won't even get into that. But he finished his first marathon. I would have a problem with having him anywhere near a bunch of people with respiratory disorders, but, whatever. Australians are crazy. Yeah, they had a marathon this weekend in Perth. But, I wouldn't doubt that we're eventually going to have one here, too. If nothing else, to run from stupid people. RDS. What's RDS? Does anyone know? So RDS, that's in adults. Usually we'll see it as reflex dystrophy, but what about in children? Looking at what it says. What do you think the R stands for if we're talking about the lungs? Respiratory, good. Respiratory distress syndrome, yeah. So this is my, unlearned, not a epidemiologist theory on how COVID is so effective. I think COVID actually affects us much like RDS, right? So it's insufficient amount of surfactant in the lungs, right? Surfactant is basically the WD-40 of our alveoli. It keeps the alveoli nice and patent and soft and supple and moist and warm. Thanks for stomping on the roof. I'm not teaching that loud. So it keeps those alveoli nice and functional, right? If you have a disorder with the surfactant, those alveoli start looking like little curled up popcorn kernels. And if they're looking like that, you can't actually get effective oxygen transfer. I'd be curious if they've looked at with COVID if this is actually getting affected, if the surfactant is being affected in these patients. Cardiac prematurity. During fetal circulation, the blood has no need to pass through the lungs because oxygenated blood is taken care of by the mother, right? So a lot of these patients are born with patent foramen ovales and patent foramen or ductus arterius, right? Meaning that those holes in the heart don't close. If those holes in the heart don't close, is that going to cause a problem for them? What do you think? Do you remember talking about the foramen ovale at all? Okay, good. Here's a question. Where is the foramen ovale at? They do have to surgically close them. You're exactly right. So why would that be? Why would that? So what is the foramen? Let's go this way. Let's go back to anatomy. That's wrong. That's the frame. Well, I'm not the foramen of. So foramen rotundum is in the head. There is a foramen ovale in the foramen ovale is traditionally in the heart. What is it between? What two parts of the heart? The two atriums. Good. Thank you. Okay. Why is it there? Well, because the mother already gives oxygenated blood, so there's no need for the blood to go through the right atrium, right ventricle, out to the lungs, back into the left atrium, to the left ventricle. So it literally just passes directly into the left atrium, so it can go right down to the left ventricle, right? So let's think about it. Baby is born, and baby still has a patent foramen, meaning that foramen is stuck open. Now baby starts crying and breathing like normal, and blood circulation starts happening, right? They're going to get a cyanotic effect because now the veins are going to return blood to the heart. That's going to be deoxygenated blood in the right atrium. That foramen is going to open. That deoxygenated blood is going to go right over into the the left atrium and go right out to the body through the left ventricle. So they're just going to be constantly pumping deoxygenated blood. Could that be a problem? Absolutely. Yeah, right? They need oxygen to survive. So we have to be kind of aware of that they are going to probably have to have surgery to close both of those foramens in the ductus arterius. Shunts the blood between the main pulmonary arteries. So oftentimes the babies and lungs don't develop normally at that early stage. Intracranial hemorrhaging is really often common. IVH, what is IVH? When you see that on a medical chart, what does IVH mean? Means problems. Intraventricular hemorrhage. Yeah, right? So it means inside the ventricles, you've got to bleed. That can cause a problem. That could be subarachnoid hemorrhage as well, epidemial hemorrhaging, any of that. And the main thing here is if you're bleeding into the brain, that's going to cut off on the space for brain development. If you get brain development cut off, you're not going to develop normally as a child, right? So this can cause all kinds of major problems. Hydrocephalus is nothing more than a fancy way of saying water on the head. That's dysregulated ventricles in the brain. Necrotizing enterocolitis. This is really bad. I've seen a couple of kids with this when they're born, premature. Literally, because the intestines didn't have normal time to develop, the body gets this idea that it no longer needs the intestines. And so it sends cells down to kill off those intestines, and it becomes necrotic. Well, we know what happens when you get necrotic tissue in one area, it likes to spread, right? So literally the colon just becomes wasted away. Retinopathy of prematurity exposed to high levels of oxygen cause abnormalities to the retina of both eyes. So a lot of times when these babies come out, they're going to be put in oxygen tents, and that can affect their vision, right? Hypobilirubin, I can say this word, hyperbilirubinemia. There we go. Whew, that was a bad one. Immature liver function, meaning that bilirubin actually gets stuck in the blood, right? And so they end up with breakdown of red blood cells. That's why babies, when they come out, are often jaundiced, right? When they come out, they're often not normal colored. They kind of look alien-like. They may be blue a little bit initially, and then they turn this yellow. And then eventually they'll normally develop as the liver starts turning on, right? So with the liver never turns on, they're going to stay jaundiced forever. Apnea of bradycardia is often common, right? These are definitely babies we do not want to leave always on their belly, because a lot of times they're going to suffocate because they have no ability to turn themselves over, right? And if you think about it, why do you think the baby's got bradycardia? Well, because the heart hasn't had to work, right? So the heart doesn't know it has to pump as hard to keep the rest of the body alive because mom's been taking care of it for them. Intervention in the ICU, proper positioning is big, right? We're going to position them in physiological flexion, mainly because the infant has less flexor tone and is exposed to gravity. Flat mattress instead of a close-fitting uterus provide flexed posture. We're going to make sure that they're positioned properly. We're going to teach parents how to assist in behavioral and motor skill acquisition, right? But again, understand if the baby is born 1 month early, that doesn't mean they're going to develop 1 month faster than other babies. It usually means they're still going to develop 2 months later, right? Even though they were born that 1 month early, it puts them behind the schedule of normal development. Provide acquisition of appropriate skills. Parents are very anxious, especially new parents. How many of you guys, so those of you that have kids, what was it like with your first child? Were you nervous? Yeah, most of them are, right? I don't know how to take that, Melissa. I don't know how to respond to that one. Um, oh, okay, I got you now. Now I was like, you left the baby in the same diaper for 3 weeks. I'm so confused. um, yeah, right. New parents are just a wreck, and not only this, but those of you that don't have kids yet, understand, right? When you have a kid, your life is changed forever. You're not going to be up till 2 o'clock in the morning playing video games anymore. You're not going to be going out to the bar on Friday nights. Your life is structurally changed forever, right? Exactly, Jackie. And that's the thing is it's kind of the way it happens, right? And you want to have a healthy nervousness, right? But you're a lot less nervous than you were when the baby was first handed to you, I'm sure. And it'll say there's a lot of parents, even up till the kid gets out of the house, they're still going to be nervous, right? Um, but parents are worried, how do I handle it? Now think about it. Let's think about this for a second. So now we have a new parent who maybe doesn't have the best home life because maybe they weren't raised properly. Baby's born premature. Baby needs all kinds of special things. And now we have to teach a new parent all these new things for this baby that's so fragile. It's really, really overwhelming for them. And it's really common for parents to break down. It's really common for premature babies, parents to just absolutely break down and feel like they have no idea what to do. My view on that has changed for a while ago. I see my godchildren, and that's all I need. I'm happy being young. I do not need to be anymore. This world is not ready for more than one of me either. But we're going to have to continually assess their neuromotor status in case we have any backslides. Provide sensory input to mimic experience that should have been gained while in the womb, right? Including swaddling or bundling in blankets, gentle massages, holding the arms in flexion, right? These premature babies, we're not going to be holding them and doing the parachute reflex with them. That's just mean. Right? Kids are miracles, Alex. You're absolutely right. And I don't need a miracle. I have nothing but respect for parents. I really do. It is so worth it. I totally agree with you, Chris. And I come from a family that's really, really, really that was really, really not good, and I came out fairly okay. So I know that if my parents can screw up as bad as they screw up, most kids will come out all right. Yeah, Elijah, I've realized that I'm mature enough to realize I'm not mature enough for kids. That's my usual thing I say. But yeah, anything that we can do, they will eventually grow, right? If anything we can do to mimic that womb experience for these children is important, right? Premature babies that are singing, and even not even premature babies. I'm going to be honest. If you ever work in pediatrics, you have to watch the children's movies because you will have to know the songs from the children's movies. You have to know the Frozen songs. You have to know that Frozen songs don't apply anymore because now Frozen 2's out. You have to understand if they're talking about trolls, what they're talking about. When I think trolls, I think Under the Bridge or D&D. I don't think about the things with the crazy hair that were weird things when I was like in elementary. No, that was high school. Right? You have to pay attention. You need to interact with the kids on their level. Trolls is a great movie. I saw one. I didn't see the new one yet. I'll have to watch it before I go treat because I'm sure they'll be talking about it. It's $20 to watch. Wow. For me, strangely enough, a lot of the kids in this area, especially when not talk premature, but even kids in general, especially a lot of the boys, are really into wrestling. Like, not like wrestling, like, real wrestling, like the male soap opera wrestling. So I had to actually learn myself on what each of the wrestlers' name were, and WWE, SmackDown. And you have to I had to learn because when they're talking about, that they're going to give me the Stone Cold Stunner, I better be ready for whatever's coming my way. I actually had a kid do that. I had a kid when I was working with them and I was helping him put his shoes on that gave me the people's elbow, and I had no idea what that was. It builds character. It creates a character for sure. But yeah, so any kid that we do, we have to be understanding of what development stage they are in, and we have to work with them at their developmental stage, right? Should have arcaded the kid. Yeah, I learned that is now too. Sweet chin music. All right, that's it for the pediatric section. I'm gonna close that down. We're gonna go back to just camera, Mr. McKeever. All right. Oh, actually, no, I do want to share one other thing. So where's that other one? Share screen, this here. Share. All right, so this reflex chart is a really, really, really good resource for you. This was developed by, obviously, by the Clipboard Online org type thing, but it was developed in conjunction with the APTA's pediatric section, right? So this gives you a really good single sheet kind of development of when things should start, when they should be integrated, and then also what the actual, how you stimulate it, how you cause it. This was amazingly useful for the last group that got through the boards. They said this was fantastic for them. Dr. Ovreskin also provided you with a chart from her class. It's, I think, on pink paper, if I remember correctly. So what do you have to know for these reflexes for, this is on Blackboard, yep, it's right underneath the pediatric lecture. What do you have to know for this? Well, when you're looking and you're gonna get questions on the boards about reflexes, you don't have to necessarily know when the onset of those reflexes are, right? So let me grab my little annotation chart here. So this here, the onset portion, is really important if you're gonna work in peds. But for the boards, not so much. That is the important part, integration. Because you're gonna have questions that ask you about a child having a certain reflex, and is that normal, right? Right, have they integrated that reflex yet? And if they haven't, is it an abnormal sign, right? So, you know, we talked about yesterday about Babinski reflex. If it's not integrated by 24 months, we've got a problem, right? Normally it develops at 9 months about, but if it's not integrated by 24, we know that we've got a problem. So all these, you guys have all looked at kind of these, right? The big ones are ATNR, STNR. They love asking questions about ATNR and STNR. What's the difference between ATNR and STNR? ATNR is also known as the what reflex? The fencer reflex, good, right? That's this one here. Whereas what's STNR? Right, the dab. Actually, you know what, now that I think about it, it's not that bad for me and the dab, right? Yeah, STNR is more of a protective reflex, you're exactly right. What does ATNR start them in preparation for doing? Rolling, good. Right? And then STNR is for getting them up and getting more functional, right? Anytime you see something that says labyrinth, labyrinth means what's starting to develop. If you have the tonic, yeah, the vestibular system, good, right? Writing reactions are important, right? The main thing you guys, again, have to know is when do these integrate by? That's the biggest thing. Right? So when I'm looking at these, 2 to 5 months is not a logical thing that I think of. I can't wrap my hand around 2 to 5 months. What I can wrap my head around is that the traction reflex should be integrated by 6 months. Because they're not going to ask you the difference between a 6-month and a 5-month. They're going to say that this reflex hasn't integrated and the baby is now at 18 months. If the baby's at 18 months, it should have been integrated by then. You see what I'm saying? They're not going to give you one where it's within that same, they're not going to give, well, is this integrated by 8 months or 9 months? That's not the way it's going to work. They're going to ask you questions specifically on out of range areas, right? Or maybe that the ATNR, the child is showing ATNR lack of integration and it's at 3 years. Well, we obviously know That's not in the right time period. The one thing I will caution you guys on is when you're looking at pediatric questions on the boards, make sure you're looking at whether they're giving the answers in years or months. Because 1 year, if you don't pay attention, if everything else is in months and you see 1 year, you'll oftentimes think that's 1 month. So make sure you're reading your answers effectively, right? Just be aware of that. They will try to trick you on years and months. So make sure you're reading. This is kind of the normal childhood development here, right? What happens when we get things, right? What's the difference between crawling and creeping? Good. That is a very common board question. You're exactly right, Gisette. They'll often ask, you know, what has to be functional in order to move from crawling to creeping? What has to be functional is leg usage, right? And then eventually they're going to start pulling themselves up. Then they're going to start creeping along furniture, right? And once we start creeping along furniture, then we're going to start creeping on stairs, right? That's when parents usually get a little terrified, is when the child starts realizing there are stairs in the house and I want to go up and down them. So all of that happens. You have running, you have walking, you have jumping. All of this is really useful for it. And then down here, this kind of talks about the outcomes with patients, right? And what this is looking at is what would be good outcomes for a patient that we want to work with head control. Can the patient hold their head at 45 degrees and 90 degrees and prone? Can they hold their head at midline? Can they rotate their head to the left? Can they rotate their head to the right? All of that we're going to test to see if they have functional movement of the head. And we get down like oral motor skills, talks about suck, swallow, and breathing, shows lip closure, demonstrates munching. Some of you demonstrate a little too much munching. Diagonal rotary chews. I bet you guys didn't know there are this many chew patterns. Diagonal rotary chews, circular rotary jaw movements, graded jaw movements, awareness. Are they able to maintain both, you know, early closing and late, or early opening and late opening of the mouth? Do you guys know what the difference between early opening and late opening of the mouth is? Because there's 2 stages of opening your mouth. There's early opening and late opening. So early opening is any time that your tongue can maintain contact with the roof of your mouth. That's early opening, right? Most of the times that we're talking, we need functional early opening jaw function, right? Because it's very rarely that we're talking like this, right? It does go into lockjaw. You're exactly right, Mike. So an early opening, so if you put your tongue on the roof of your mouth, right now, do it. I'm watching you all. No, I'm joking, I can't see you. Now lower your jaw until the tip of your tongue is still touching the roof of your mouth. That's how far you have for early opening. Late opening is from the distance that that tongue lifts off the roof of your mouth, all the way as open as you can get your mouth. Those all provide for different things, right? Early opening is in dealing with speech, right? And a little bit with drinking, sucking, swallowing, stuff like that. Late opening deals more with feeding our face, right? We need to move our tongue out of the way so that we can get food in our mouth. And we'll look at lockjaw. Oftentimes people with lockjaw end up stuck in the early opening phase. So they can't open their mouth more than this, right? And a lot of that's the problem with the TMJs in the back, right? I've talked about this before. Patients say, I've got TMJ. Well, I look at them and say, congratulations, I have 2 of them. What they're really saying is they have TMD, temporomandibular disorder. But yeah, so, and some of you may even, as you go into that late opening phase, may get a little bit of pain back here. And that's probably because you have really, really sensitive temporomandibular joints. But we need what with babies? They need to be able to do this stuff. Are babies able to drink without spilling liquid, right? That out of all parents, that's probably one of the challenges they get frustrated with, is when we start moving from sippy cups to regular cups, how much of a mess can they deal with? And parents need to move from sippy cups. If they don't move from sippy cups, they don't learn functional skills for real world, environment. It's not like you can go out to a restaurant and say, Can I have a Coke, but I would like it in a sippy cup, please? Right? They need to have functional development in the real world. Putting on clothes, taking off clothes, zipping and unzipping. The two things that probably become the most difficult for children for some reason is zipping and unzipping clothing, especially if you have to hook the zipper. And some of us struggle with that as adults. And then tying the shoes. Right? Tying shoes is this rite of passage almost for kids, right? Do you guys remember when you learned how to tie shoes? Do all of you know how to tie your shoes? Just checking. If mom still ties your shoes. Right? It was a rite of passage though, wasn't it? It's future self ties, right? You know, for me, a funny story about me, I can't tie my shoes in the loop and swoop method. I have no ability to do that. I cannot do loop and swoop. You could try to teach me all day long. I can't do it. I never learned it as a child. You can, right? You would think, Michael, for some reason, out of all the things, I can learn advanced calculus. I can't do the loop and swoop method. I don't know what my problem is. And it's funny because I've had friends who are like, no, come on, I can teach you how to do it. And they're like, come on, I'll show you. And I fail miserably every time. I learned the bunny ears method. That's how I learned how to tie my shoes. That for some reason that makes sense. And now I'm old and I only need to tie my shoes and nobody can tell me that I can't tie it with bunny ears. So, take that, school. Right? But it's really difficult for kids to tie shoes. It can be difficult for adults, right? That's why when we end up with the stroke, a lot of times some of the stuff we're going to have them doing is a lot of stuff we have kids doing. When you look at a lot of this stuff that they're talking about here as goals, all of these goals apply to kids, but we could literally just take this chart, swipe out pediatric outcomes, and put in there post-stroke outcomes, and this chart would be just as viable. Right? Let's think about transfers. Patient will demonstrate mobility by performing sliding board transfers as a kid, transfer from the bed to chair to toilet to floor to chair, standing from chair, sitting in chair, performing standing pivot transfers. That may be all the stuff we're going to work with a kid, but that's equally working with adults that have strokes. So this can be really useful if you're looking for something to work with stroke patients where this chart is just as useful for that. It's kind of funny, right? Taking patients back to the basics for this. But this is up for you. I put this up. A lot of the students that graduated last time that passed their boards put this in their little clinical binder and kept it for studying. Those that didn't pass it, I can't help them. There is no lecture on X-ray and imaging, but I just wanted to talk about imaging real quick because it's important and how much you need to know for imaging. As PTAs, do we have to understand how to read an X-ray or an imaging? Nope. You're exactly correct. Is it a good skill to learn? Yes, absolutely. It is a good skill to learn. Be careful, because I see a lot of PTs and PTAs learning the skill how to read an X-ray and then giving up information that's beyond their scope of practice, right? I can't tell you how many students I've had over the years say, hey, can you take a look at this X-ray? Can you take a look at this MRI? Tell me what you see. And all the time that happens, I have to preface this. I am not a trained professional, so I can only give you my biased opinion based upon what I'm seeing on the screen. One of the other students in the other cohort just asked me to look at their MRI of their knees and what I thought of it, and if I thought that the radiographer, as a PT X-ray especially, would be deficient, especially coming up. I'm going to talk about that in a second. So reading X-rays and that could be a challenge, right? But understand, X-rays are used to look at what? What are X-rays specifically used for? Bones, right? X-rays are for hard tissue. You will never see a sprain, a strain, a tear, anything like that on an X-ray. What do you need to look at those? MRIs or CTs, good. Right? Or whole body scans as well, PET scans, right? Those will provide you at that detail level. So that's the thing you have to understand is just because a patient has an x-ray, can you look to see if I tore my ACL? I see bone. Right, exactly, Russell. This is the thing we have to be careful of. I've looked at x-rays and I know that my face has given away what I've seen on the x-ray. I spent a good bit of time looking at x-rays, and just because it interests me, and we have a radiography department on campus, and I oftentimes want them to kind of challenge me to see what I see. Um, but it is a skill to look at those and understand what's going on in them. It's not easy. And then you get to the MRI, and it's a totally different skill. Look, if any of you have actually seen an MRI, it's crazy. I was planning, I can't find my MRI. I was trying to find my MRI at my neck so we could look at it. I just can't figure out where it's at. So as soon as I find it, we'll kind of look through it because it looks different than an x-ray. Exactly, Russell. So it puts you at a thing. It is scary, right? Why do we need to know more about x-rays now? Well, because in several states now, PTs have the right to order imaging. So they are giving PTs the ability to order imaging. Does that mean the PT is going to read the image? No. What the PT is saying is, hey, I think you might have a fracture, so I need you to go get an x-ray. And they can write a script to go get an x-ray. Do you think that should be in the PT's wheelhouse? Yeah, I absolutely think it should be. Especially if we're going to call them DPTs, they need that ability. Because this is the problem we run into right now, specifically in this area. Let's say I'm a PT now, and I suspect that Alex Lopez has a fractured femur or something like that. Alex can't go just get an x-ray unless he wants to pay out of pocket. If he wants to pay out of pocket, he can absolutely go get an x-ray. So I have to say, hey, I think you have a fracture. You need to go see your primary care physician so that you can get a referral so that you can go get an x-ray, so that x-ray can be read by a radiographer who can send it back to your physician who can send it to me. Does that delay treatment? Yeah, right. PT, it'll help us be more adaptable and actually help patients without a lot of middle people, right? I love it when people say that, when we have the system, it's broken. Well, it is broken, right? Now, why do we put this system in place? Well, because way back when I was growing up, we ordered too many x-rays, too many MRIs, and the insurance company said, I'm not paying for it anymore. That's really why we're in the situation we're in right now. And to be honest, most insurances now won't even cover an MRI unless you've done multiple weeks of physical therapy, which is a bonus for us. But let's face it, if you have a completely torn ACL, is physical therapy going to help you get better? What do you think? So you completely rip the ACL off the femur. Not really, right? We can help them learn protective techniques, right? We absolutely can help them that way. But we're not going to repair that ACL, right? The only way they're going to get a repaired ACL is by going in for surgery. But let's take C1, Cigna, for example. If the patient is suspected of having an ACL tear, some of Cigna's bylaws say that the patient has to be seen for PT for 2 to 3 weeks before we can order an MRI. In reality, in that 2 to 3 weeks, what if I have a partial tear? What could happen in that 2 to 3 weeks? Yeah, full tear, right? It's kind of silly, right? It really is. And I've heard it from orthopedics. Orthopedic surgeons are frustrated by this. It's not like they hate us, but they're like, I don't know why I'm sending them to PT when I know as a surgeon I have to operate on this patient. Well, why do they do that? Because a lot of times they'll go get an MRI and guess what they find? They don't have a tear. Right? Until we get affordable imaging, we're not going to be there. And imaging is a multi-billion-dollar industry, right? But specifically, Indiana now has rights to order for PTs to order X-rays. Not Las Vegas. Pennsylvania has it. Maryland has it. DC has it. All the PTs in the VA system should be able to order X-rays now, if they feel the patient needs it. Now, most of the time, the PTs are still going to consult with the docs. And because interdisciplinary approach is much better than just shooting off the hip, right? I had PTs before that'll call the orthodoc and say, hey, you know, I really think we need to get this, that, or the other for this patient. And docs usually do work with you really well, right? What is the downside to x-rays? Cancer, right? Exactly. What's your chances of a normal x-ray of developing cancer? What do you think? It's actually about one in so it's about 1% chance, so 1 in 100, right? So a normal X-ray, 1 in 100. CAT scan can be up to 50 times that, or a CT, right? That all can be a lot more. Yeah, exactly, Alex, right? So every time we expose ourselves to those X-rays, we're putting ourselves at greater risk for developing cancer, right? That's why if you see an X-ray tech, they have that little badge on their chest. Did anyone ever see their little badge they wear? And they have a little color ring. And that color ring determines if they spent too much time around X-rays. What happens if that changes color? You have one good, right? What happens, Kaylin, if that starts showing signs of warning, 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 danger? Yeah, it means you've been exposed to too much radiation, and a lot of times those clinicians then have to be pulled out of working with the X-ray for a while, if not permanently, right? So now we've gotten a lot better now, right? We know that we have to go behind the lead walls. We know that, you know, we shouldn't be in the room. But let's say the patient needs to have a standing X-ray. There's a lot of times where I've been down in the X-ray room with the patient while they're getting a standing X-ray because I'm providing them with support and helping them stand, right? Now, usually they'll give you the big lead vest or the big lead dress, as I call it, but that doesn't totally protect you from it. Now, the X-rays are a lot more focused than they used to be, right? The X-rays used to be whole rooms. Now they're little beams that fire and they get the exact shot of it. Exactly. You see the printout of the history and the radiation. Exactly. So that's the downside to X-rays and CTs. Now, what is an MRI? How does that differ from an X-ray? Yes, magnetic resonance imaging. In reality, what an MRI is sonar. For those of you that are interested in like boats and stuff like that, or ships, or maybe you were in the Navy, an MRI is sonar. It's going to send off sound waves, magnetic resonance sound waves, that are going to bounce off the medium, bounce back, and it's going to develop this picture of the whole area. Can an MRI detect a fracture? Or is it only X-rays? What do you think? Yeah, MRIs can actually detect fractures. Yeah, it can look at the soft and the hard tissue. So then why don't we do more MRIs if we know that MRIs aren't as harmful? Expensive, right? Good. And what do MRI machines look like? Yeah, the machine itself, right? Scary. Yeah, they're huge, right? And they do take longer. You're exactly right, Kaylin. They can, I mean, for a good MRI, it can take 20 to 30 minutes, right? Where you're in that little tube while, you know, Bob is talking to you. Okay, stop moving. Okay, the test is going. Womp, 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 womp the whole time, right? So that's why a lot of times we don't do MRIs. I think as MRI technology gets better, we're going to be transitioning to phasing out X-rays. I really want to be honest. Eventually, I think we'll phase out X-rays because we just know the harm in the X-ray. Some docs will still hold on to them because docs do that. But MRIs are kind of the wave of the future. There are even some science that are now showing that 3D body scans may be the way, using an MRI technology where they can literally take a full 3D body scan of your body in a couple of minutes, which is just amazing. So the interesting thing is, how many of you have flown across country this year? Any of you? Like maybe gone to New York or Florida, Atlanta? All right. So for those of you that have done it, you had 10 X-rays. How about that? Nope. When you're in the plane, you are exposed to as much radiation as you do in an X-ray. Actually, 10 times, 10 times that if you've flown once. So think about that, right? So when patients are scared about getting an X-ray, but they're willing to fly, it's just an abnormal fear, right? So yeah, could you get cancer from X-rays? Absolutely, you could, right? But it's not like it's as dangerous as people are really worried about, right? What about at the airport, that circular thing that they put you in? What is that? Where they make you stand, hold your hands over your head, and that thing spins around you? Is that an MRI or is it an X-ray? Yeah, it really is a low level, the body scan, it's a low level MRI. It's really what it is. It's going to use those waves going off and bouncing back to show a picture if you've got metal on you, right? I have to go through those when I go to either go that way or I have to get patted down constantly, because I have so much metal in me now. Just going through the metal detector, they're like, okay, come through. And I'm like, over there, body scan. Like, no, you can come through. And as soon as I go through, the beep goes off and they'll send me back over there anyway. They just don't listen. But yeah, it's true, right? That's a low level MRI is really what it is. So it's not necessarily an X-ray. So a lot of people are scared about that. Now, that can affect your, when the stuff that goes through, absolutely. When they're taking all of your stuff through that machine, that's an X-ray. So I always question people that pack their food and then send it through the scanner. I don't know that I do that. Oh, yeah, I didn't think about that, did you, Ian? You just got irradiated food. The good news is if it has any virus on it, it should kill it. Same as microwaves, exactly. Yep, exactly. Except don't microwave your money. It does not kill COVID. Please don't any of you microwave your money. Scorpions. Yeah, scorpions does kill scorpions. So then we get into PET scans, right? And this is not, I'm scanning my dog. That is a different type of PET scan. What is a PET scan? Anyone know what a PET scan is? How about you, Kaylin? Do you know what a PET scan is? I know they use them for cancer patients. Good, okay. What does PET scan stand for? Positron emission technology. That's what PET scan literally means, right? So a lot of times when they do PET scans, they're going to have to give you something medicine-wise in order to react with the positrons, right? So positrons are little particles that fly in through the air and blah, 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 and that reacts with whatever chemical you have. It irradiates that chemical and lights it up, right? It is contrast. Good, yes. Now there's difference. There's also contrast for MRIs too, Alex, especially like if you're getting something where you're going, checking your guts. They can give you contrast for your guts too, but all that does is it adds enough metal to your stomach to line your stomach so they can see everything, right? A lot of times with PET scans, they have to give you a radioactive chemical that will react and has a half-life of a couple hours so that when they hit you with the PET scan, that whole area lights up. A lot of times brains are what they do PET scans of, right? And it really kind of lights up the whole area. Those are the pretty pictures. Have you ever seen any of the PET scan pictures where people's brains are all lit up and you can see what active area of the brain is active, what's inactive, all that fun stuff? It's really amazing. Functional MRIs are another way they're doing it now, right? But all of those kind of look at the chemical activity of the body. That's the main thing with PET scans. So that's why a lot of times they're used for exactly, I think Krista said it, that are used a lot of times in the case of cancer, where we're looking for abnormal growths. we're not going to ever have the reason to order those, right? Most of the times, if PT is going to order anything, it's going to be either an X-ray or an MRI. So if you have a patient that's scared of going to get an MRI, I understand the fear of it, right? But an MRI is less invasive than an X-ray, and an X-ray is still safer than getting on a plane and flying. So that's a lot of times I'll use that with my patients. They're like, I know the doc says I need an X-ray, but I'm terrified of going and getting an X-ray. You know, I had a patient that on a regular basis flies to Phoenix and back every week, 2 times, right? And he had, he thought he had a fracture of his tibia, or not his tibia, his fibula, and he didn't want to go get an X-ray because an X-ray is going to expose him to radiation. And, I had to tell him, look, you're getting more exposed to radiation flying to Phoenix and back twice a week than you're going to get from that one X-ray. So sometimes we do have to be a little bit of the reality check for patients, right? Like right now, people are terrified of this COVID. They should be terrified of it, right? But in reality, I'm not afraid of getting COVID for fear of me. I'll probably get sick. I'll be fine, get through it, blah, blah. I'm scared of getting COVID and giving it to other people. That's really what we should be afraid of. Same thing here. X-ray is not going to, in the grand scheme of things, X-ray in all your life one X-ray is probably not going to cause it, but it could cause cancer. It absolutely has a risk involved, just like anything else, right? If you go outside right now and get a little bit of sun, that little bit of sun could cause you malignant melanomas all over your house, or all over your house, all over your body, right? So there's inherent risk in everything. We have to mitigate risk, right? So that means if the patient doesn't need that test, then probably we don't need to order it, right? If I take a tuning fork, smack it, and put it on the ulna, and all of a sudden the patient screams, do I necessarily need an X-ray to show that that bone is broken? What do you think? No, I know the bone's broken, right? Just that alone is telling me there's a fracture somewhere there. Now, what the X-ray could help me show is if it's a stable or unstable fracture, right? I'm willing to bet it is. If you ever are wondering if you have a fracture, that's an easy, quick test. You put that tuning fork on the bone, and man, whew, yeah, it lights you up. Have any, like the tuning forks, you need to take a tuning fork. Have any of you put the tuning fork back on your mastoid process and heard what it sounds like? Those sound waves will travel all the way in your ear. It's actually kind of wild. So you guys are all going to do that when we go back to class. Ooh. And one of you like, I got a fracture on my mastoid. You buy a tuning fork. Yeah, I keep one in my package that I carry with me. Because it's a good, quick scan, especially working with kids. If mom says, he fell yesterday, I don't know if he broke anything or not, I can smack that tuning fork and be like, probably not. But again, I'm not a doctor and I'm not going to make the diagnosis. But a lot of PTs will do those quick screens that way. In the ER, they're essential. Especially if you're talking like, in the med bag of something in combat medic or something like that, tuning forks are essential. It's not like out in combat, we can carry with us an MRI and an X-ray machine. Right? In the field, you know what? That tuning fork is just as effective as an X-ray and an MRI. All right, so last thing we're going to cover and talk about today is PNF. And we're not going to hit PNF totally like high level like we did last semester. What I gave you last semester was distilled down what you need to know for PNF. I know you didn't maybe get the most PNF when you were in Therex 1. Up and in, down and out, good. Right, that's not all you need to know though, Bison. Remember I gave you that whole list that was on the board and we kind of went over the stuff like that? You do need to know those. The good news is they've cut some of the PNF questions out. They're talking about, on the last call I was talking, they've kind of stepped down the PNF questions because they felt that PNF was taking up too much of the neuro section. So that's a bonus on your part. It means you're going to be less asked about maybe, reciprocal inhibition, stuff like that, the theories of PNF, and it's going to be more about integrating PNF into their usage, right? Using the diagonal patterns, how to help with core stability, stuff like that. That's the good news, is they're taking a little bit, they're not going to ask you about Sheridan as much, right? Who's the father of PNF and everything like that. And then the founders of PNF, they're not going to ask you those type questions anymore. They're going to ask more functional PNF questions, like, if a patient is having difficulty reaching outside of their base of support up onto shelves to grab things, what pattern is most appropriate to work with the patient? So you've got to be able to say, okay, right? So you've got to be able to think. So D1 goes which way? Okay, so I've got D1, I got a D2. An extension, we're all over the place. What about D2 flexion? Yes, right? It's the shoulder, remember that, right? So you've got to be able to distill that question. So the question said, the patient is having difficulty reaching outside of their base of support and up onto shelves, right? So let me slide back some. This is what they're reaching for, right? That's throwing the sword away, isn't it? Or the platter, however you want to remember it. That's out here. So what you have to think is the pattern I need to go needs to go up here. So D1 starts down and out, comes up and in, right? Whereas D2 starts down and in and goes up and out, right? So the D2 pattern would be most appropriate for patients that need to reach outside their base of support, right? Remember, this is going from D2 extension into D2 flexion because the shoulder is the joint we're talking about. Does that make sense? Here, I'm in shoulder flexion. Here, I'm in going into shoulder extension. Because if I kept going, my arm's going to go past my body. That is the thing. The trick questions you're going to get on that is you're going to go down, and the answers will be D1 flexion, D1 extension, D2 flexion, D1 extension. You have to make sure, because this seems like it should be extension, because you're extending beyond your body, right? But in reality, that's flexion because the shoulder joint is moving into flexion. So those are the kind of things. So let's look at a patient has difficulty with the right shoulder and is having trouble tying their left shoe while it's on the ground. So we're talking right shoulder, right? D2 extension. Good. Do you see how those questions are going to work? Does that make sense, though, a little bit? So let's think of one. So a patient is having shoulder issues and having trouble with self-feeding while using the right arm. D1 flexion, good, right? Because that's going to come up. That's the eat the apple, throw the apple core away. Eat the apple, throw the apple core away. Does that help you understand how the questions are being reformulated for PNF? Right? What kind of one could we use for D1 extension? I'm trying to think, like that's a weird one. I don't know what the exact, maybe a seatbelt. Okay, that could be valid. I mean, yeah, because you're pulling it down and putting it in. That's actually, look at you, you're smarter than me. Seatbelt is exactly what it could be, right? You're putting the seatbelt hook in, right? And honestly, when we unhook the seatbelt, we go up into flexion, right? I didn't even think about it. It was like that pattern, it does make the seatbelt, right? So you're hooking the seatbelt, you're unhooking the seatbelt, you're hooking the seatbelt, you're unhooking the seatbelt. Anything that helps the patient understand it. Reaching back to the edge of bed could be too, right? Yeah. Reaching back to scratch your butt. Or the other one, the big one that they use for that, the big one they use, now that I think about it, it just hit me. The big one that they use is patient is having trouble with self-cleaning after defecation. In that case, it will be, right, D1 extension. That's the one we're going to kind of work. This one, so you could technically work D2 flexion, I guess, but yeah. I mean, I don't think that's exactly the direction. And reaching across to wipe your butt doesn't exactly work well. And then for the rest of them, it's just knowing if you have alternating isometrics that at some point there's an isometric hold, right? And your stretches are important. So the ones that we covered on stretching are important because that's the key thing. Understanding specifically with stretching, the big thing with stretching that's on your boards is, slow and long beats quick and short for stretching, right? So you get better benefit long-term out of slow, long-held stretches than you do out of ballistic quick stretches, right? But ballistic are the best way to get a quick response out of your stretch. So say you were warming up to go for a jog, right? Long stretches will benefit you long-term, but if you don't have time to do a long stretch, ballistic stretching is the way to go, right? So you're bouncing. If you want to get the most benefit out of everything you do, slow and long held stretches are the best way to go, right? And if nothing else, yoga has taught us that, right? It's not like yoga when they're doing, downward dog, they're going down, back up, and down and back up, and down and back up. They're going down and holding it, letting the body settle into that position, right? I don't know what kind of yoga would just be bouncing all over the place. That'd be like ADHD yoga. But yeah, so that they made some structural changes in the way that they're going to be doing PNF. And the main thing is taking some of the theory out of the PNF questions and going more for the function of PNF questions. And I appreciate that, honestly, as an educator, and I hope you guys should appreciate that as well, because that means you have to learn a little bit less about, you don't have to understand who's the people that develop PNF. You don't have to understand how it affects with Sherrington's laws, right? Sherrington's first law, second law, third law, stuff like that. And you have to know how PNF is going to help your patient. And PTs really appreciate it too, because they don't even get a lot of the stuff you guys got for PNF. I'll be honest, they don't. I actually just gave my PNF lecture to one of the, not here, but down in Tucson, one of the clinics down there asked me to give a whole lecture on PNF because their entire clinicians were doing it wrong. And the owner of the clinic said, I need you just to give your lecture that you give your students on PNF, and you can imagine how much those DPTs loved having a PTA lecture them. That was fun. Does that make you feel a little bit better about the PNF questions, at least? I hope it does. Yeah, right, okay. So don't totally freak out. When I tell you it's time to freak out, it's time to freak out. We're not at the freak out phase yet. Ian will tell you, looking at probably base camp, he's a little overwhelmed. I'm guessing if he's looked at it. A couple of other users said that you've gotten an older score builders book and stuff like that. You can understand being overwhelmed. We'll get there. I'll get you to freak out phase. We're not quite there yet. All of you should have, do you all have the score builders app, the PTA365? Are you guys doing the questions every day? Good. Dash, Mike. Yeah, those questions are really good for helping you prep for the boards. So there's an app that is called PTA365. Let me see if I can bring it up here real quick. This over here. What? No. I've got screen share here. Where is my stupid screen share? So here's PTA 365, right? It's an app by Score Builders. It is free. And every day it gives you a question. Oh, it has 600 questions down for $29.99. Interesting. I didn't know they added that. The MPTE PTA one's not bad either. You have your own app? Wow. I did not know that. I'm not screen sharing, am I? Share. Now I am. There we go. Now you guys can see it. I've always wanted to develop an app, just the Content Master. Yeah, the Content Master is another one. Good. I was like, you developed your own? I'm impressed. Okay, so all of this can help. This is really good for helping prepare. This is all of the stuff. You guys can see Score Builder's website on screen, right? Good. All this stuff is good. So the on-campus review is what we're providing for you. I'm trying to see if we can get that earlier and maybe do an online review with them. Content master flashcards are good. Base Camp's what Ian's talking about. There's the Base Camp 365. So these over here, just to let you know. So this ACE and the Online Advantage Student, all this stuff here, these are going to be your most expensive things. These just provide you with additional testing resources. I would not spend my money on them right now. Those are what I recommend to people that just want that extra practice exams. I would not spend a lot of money on this right now. Oh, you already bought it? Good. Well, hey, if you buy it, great. I'm just going to tell you not to spend money on it if you don't have it. The Content Master, they do have a Content Master app. How about that? I did not know that. This is, if you have a PTA exam book from somebody else, this is the most recent version. The green version is the most recent. Now, so as a PTA, I'm going to stop my recording right now.